as we speak. So wonderful. Again, thank you all for being here. I'm going to start with Professor Venkatapuram. Sridhar, thanks for being here. Sridhar Venkatapuram is the Senior Lecturer in Global Health and Philosophy at King's College, London. It's really a joy to have you. Thank you for joining us.
Thank you very much, Brian, and hello to my fellow panelists and also to all of you for making the time today. And no doubt many of you are coming from different backgrounds. And so I've been given 5 minutes to make sort of essentially an argument. And so I'm going to do that. And I hope that many of you who are not coming from philosophy won't be too turned off by it, but also I'm interested in the philosophers to see whether I can articulate sort of a decent argument within this short period of time. So I'm going to sort of start off by saying that usually bioethics is about how we deal with sort of different kinds of difficult decisions within the healthcare or research setting. Today's sort of topic is something that takes us backwards in a macro sense of actually saying, well, how can we ensure that everybody actually gets access to that healthcare setting in the first place? And so I'm going to make the argument in 3 ways. One is that I think fundamentally, particularly in America, we've misunderstood the concept of health. And so many of you who've studied philosophy of science will know that there's been a long-standing debate and literature on the conception of health. And so many of you also who are not part of this might actually think about why we value health in different ways. Some of you might be really motivated by ideas around unhealth or disease or ill health is actually sort of cause of suffering and preventable death. And this is something that's morally bad and that we should do something in order to reduce people's suffering and also help them live long lives. And I think that's an admirable and sort of valuable way of looking at it. So, but more sort of in terms of the intellectual idea and conceptual framework of the concept of health, a dominant view is that health is the absence of disease, or more, another way to think about it is that health is sort of when the body parts are functioning in sort of statistically normal ways, sort of what average functioning across human bodies. And so whether your body is functioning statistically normal. And the reason that we sort of provide healthcare and medical care is to sort of make sure that everybody's functioning gets back to normal. I think that this is wrong in lots of different ways. And rather than going through the argument, I'm just going to tell you what mine is, which is that I think health is much more of a moral concern. And it's actually, we would be better off thinking about health as sort of something that we are able to be and do. Sort of health is actually kind of a capability. And not only is it analytically a capability, but in terms of moral sense, it's actually a kind of freedom. So just like we think about various kinds of freedoms, freedom of speech, freedom of movement, et cetera, we should start thinking about health as actually a physical freedom to be able to be and do things that we value. So if you come along with me and sort of say, okay, I kind of go with you that health is valuable because of this moral aspect of it. It's actually about how we can pursue good, flourishing lives, and health is an instrumental part of it. But also health is an intrinsic part of well-being. Then healthcare is an instrument that ensures that we're able to have that. So I think that it's that reason that because healthcare allows us to pursue the lives that we want to sort of pursue and also sort of help protect our well-being, healthcare is a kind of a basic thing that we should ensure that every person has access to. So that would be 2 things that I've said so far about how to think about health and how to think about the right to healthcare and why we should think about giving people a right to healthcare and why we should recognize the right to health in international law. The third part, which I think is really as important, is that because we care about health, what we need to understand is that healthcare is just a small part of it, that what we care about is people able to be healthy. So what we're interested in is the determinants of health and also disease. So these determinants are not just about having a hospital or a clinic available when you're sick, but actually the determinants that impact whether you're going to be exposed to dangerous particles, viruses, et cetera, but also conditions, what working conditions, living conditions, but also increasingly we're seeing research that it's about relationships, right? So in terms of racism, discrimination, sexism, homophobia, all of these things not only are wrong in different kinds of ways, but they actually impact disease in people's bodies. And all of this leads to people living less flourishing lives and having shorter lifespans. And so therefore, this is one of the major reasons that we should be addressing the determinants of health. So I hope in that sort of quick jog through sort of my argument, what I've tried to do is sort of say, here's how we should think about health as sort of health as a capability and a freedom to pursue the lives that we value. Second is that because we care about health in that way, healthcare is something that we need in order to protect that freedom. And third is this idea that we should be thinking much more about a right to health and the determinants of disease and sort of addressing those, particularly the social structural issues, and thinking much more about sort of the wider determinants of health, which includes access to healthcare. Okay, Brian, I hope that did the job that you asked me to, and I hope I didn't go over 5 minutes. Thank you very much.
No, thank you, Sridhar. Perfectly timed, and yes, I mean, for the audience, I know the clarity of the 3 points was helpful, and I appreciated how you've now broadened our conversation. Not that the important thing is not just a right to health care, right? But that this is actually connected up with a broader consideration of health. So you've sort of pushed the bounds. And for folks who are more interested in this, Sridhar has got a great book from 2011 that I think starts this connecting it up with capabilities. And then I know you've done work increasingly since then. So we can jump back to the Q&A, but we've got one really nice position now on the table. And I want to turn to our second panelist, Professor Mark Cherry. So Professor Mark Cherry is the Dr. Patricia A. Hayes Professor in Applied Ethics at St. Edward's University. Professor Cherry, thank you for joining us today.
Sorry, I had to figure out how to unmute myself. You think after a couple of years of COVID, I would have figured this out already. Professor Pilkington, my colleagues, it's a great joy to be here with you today. My greetings from the Republic of Texas, because obviously we are separate from some other country we will not mention. It is one of the things, if we're going to talk honestly about rights to health care or to even to things like health, we need to acknowledge the following sets of circumstances. And again, I'll sort of break it up into several small points so we have more time for conversation. First, many of the best ways to improve the quality and quantity of life, to improve health, to reduce the burden of disease, fall totally outside of the sphere of medicine. Effective trash pickup, sanitation, and safe disposal go an immensely long way. Clean water supply, adequate nutrition. These are central to understand in terms of their implications for quality and quantity of life. Second, no country provides equal care, best of care, unlimited physician and patient choice, does so without any rationing, and still manages to have cost containment. I don't know that that's possible in the real world. Sometimes philosophers sort of fantasize about it. But in terms of the real world, all countries, all of them, need cost containment. So they give up on one or more issues regarding equal care, best of care, or they find ways to limit the choices of physicians and patients, which is to say that all systems of healthcare ration because they have to deal with cost containment. The third issue is that there is no general moral agreement regarding the nature, extent, or requirements of what are claimed to be rights to health or rights to health care. We do not agree on the nature of the good, of the right, of the virtuous, or of the just. We do not even have agreement regarding the nature of health or the proper requirements of health care. The language of rights itself is strategically ambiguous. The term rights can mean many things. Sometimes the word rights identifies a sphere of moral jurisdiction. Patients, for example, we usually talk in terms of things like informed consent. We ought not to touch them or use them without their permission because they have a sphere of moral jurisdiction over themselves. Sometimes the language of rights is goal-directed. It would be useful if others got access to something, such as a vaccine. Sometimes rights language is simply a way to indicate a good. We say you have a right to it as a way of talking about this being a good thing. Other times, rights language is used rhetorically as a way to set out a political agenda. It has a kind of a powerful backing to it. That powerful backing doesn't go far back in terms of philosophy, in terms of historical philosophical positions, but contemporarily it has a very powerful language. Sometimes rights language puts a duty on others, but not always, and not even necessarily welfare entitlements. Now, Professor Pilkington has already yelled at me not to go too far into the weeds of these sorts of philosophical debates. So I'll just note this very small element of the difficulties of untangling the language of what is rights, what one might think of as a right. The essential philosophical point to take away from this is that healthcare rights, or rights to health, are the creation of a political process and compromise. They are not necessarily the result of rational philosophical analysis. It's probably more useful to think of rights in the sense of it being a political modus vivendi, a sort of arrangement allowing conflicting parties to coalesce, to coexist more or less peacefully. What this means is that insofar as we think that there are rights to health or to healthcare, we still need to determine what kind of a system ought to be created politically. One might think of a sort of a Singaporean type system. They have a very limited government-provided universal tier, I mean, very limited, coupled with mandatory medical savings accounts. They get very good results. We could think of and compare that to a Canadian-style system with mandatory participation in universal single-tier healthcare system that one is by and large unable legally to escape, where you could use your extra money to buy better food, better vacations, better cars, better bourbon, more philosophy books, but not better healthcare. And one might wonder why one would lose the freedom to buy more healthcare. Third, you might compare it with another kind of system, something more like Germany's, for example, where there's a robust state-based tier, but it's legally to buy out, either on a case-by-case basis or indeed altogether with private insurance. So those are just four basic areas to think about in terms of conceptualizing the discussion. At that point, I will stop and turn back to the panel. Professor Pilkington.
Thank you, Professor Cherry. I very much appreciate the breadth of the comments and that you followed my lead and didn't get too far into the weeds. I also, and we'll turn to Dr. Thomas momentarily, but noting an interesting similarity. Though we started with rights language, there's been some critique and maybe an agreement between our first two panelists about thinking about the broader determinants of health, as Professor Cherry had opened his comments as well. So now I'm going to turn to our third panelist, Dr. Florian Thomas. Dr. Thomas, thank you so much for being here with us today. I appreciate it very much. Those who are regular attendees of the COVID ethics series will recall Professor Thomas spoke eloquently with us, over a year now, on the session in which we asked questions about access and politics related with COVID-19 and disability. Dr. Florian Thomas is the founding chair and professor of the Department of Neurology. He's also the interim associate dean of faculty at the Hackensack Meridian School of Medicine. Florian, thanks for being with us.
Thank you, Brian, Mark, and Sridhar for your comments. So I'm going to present my comments from the point of view of a practicing physician, as well as that of a person who has been charged with building various subspecialty programs pertinent to neurology. I thank Sridhar for providing, for me as a non-philosopher, a theoretical framework with which to grapple with WHO's definition, which has always rung true to me, of health as a state of complete physical, mental, and social well-being, and not merely the absence of disease and infirmity. I've been fortunate or unfortunate of having lived and spent considerable numbers of years in some of the several systems that Mark alluded to, Germany, United Kingdom, Canada, I remember taking my 8-year-old daughter, whose wire on orthodontic braces was broken and stuck into her cheek, into a clinic in the Lakes District in northern England, where this minor issue was fixed, and there was not even an opportunity to pay for this, because that's how the British health system works. I had a newborn in Canada, and I embraced that system fully without ever witnessing any lack of healthcare for my patients or for myself and my family. Now, I completely agree with what Mark said about every country limiting access to health. But I would draw a distinction between single payer systems, where even if the compromise and the decisions on how to ration healthcare are not terribly explicit and may not reflect an open debate among the society on where to set limits, versus, and that's obviously the case for better or for worse in both Canada and United Kingdom, versus the United States, where there is very serious rationing of healthcare for those who cannot afford it. And what Sridhar said about the right to health, I mean, that really rang true to me when I think about the degree to which societies restrict the right to health. When we oblige people in a single track economy, such as a mining community in Kentucky or West Virginia, or in England, or anywhere else, to work in the mines, we have denied those people the right to health, because those people will die of professional hazards associated with their profession. And this obviously has been a big issue recently, where employers either directly prevented or enticed employees from masking when working as $12 an hour plus tips servers in restaurants. Those waiters were denied the security, the emotional security from illness, from COVID, and they were denied any kind of protection from COVID. So in that sense, I'm very much aware of the limitations that this society imposes on access to health, not to mention access to health care. Just yesterday, I've been talking to one of my patients who is very disabled, has very limited socioeconomic means, is not internet savvy. She cannot get to a COVID vaccination place. She doesn't know how to schedule it. And even if she did, she would not be able to get there. So those are what I face. And I, as a physician, am in the unenviable position of having to prescribe this person life-saving immunosuppressive medication so that the autoimmune disease doesn't shorten her life.
Thank you, Dr. Thomas. It's always essential in these conversations to have the perspective of a practicing healthcare professional, and your ability to lay these things out so clearly and also connect them up with the philosophical heft is, well, it's always great to have you on these panels. Thank you. The points about access are well taken, and I appreciate them. An announcement for anyone in our audience who has any questions. You can send questions in via the question and answer feature. Also, you have the opportunity, as you do all the time, to tweet us at Seton Hall Bioethics, or to tweet the moderator at BCP Ethics on Twitter. Some folks prefer that. So I'm going to take the moderator's prerogative and start out with a broad question for the panel. So, and I know you all will do well to not sort of let me get dragged into the philosophical weeds. So we've discussed a bit rights to health and rights to health care. So we have a distinction which between the two, which all of you have referenced. And you've all wonderfully highlighted those other kinds of determinants, those other kind of factors which impact health. So here's an old and a novice question. Aren't rights, or whatever language we want to use, the sorts of things that would have corresponding duties or that we would want to be able to guarantee in some kind of a way? If I have a right to certain sorts of things, there's going to be some folks who have a duty or someone who makes sure that I should get those things. If not, we have a problem. But so I can conceptualize what a right to health care might be, right? Guarantees to go and visit Dr. Thomas. It's tougher for me, even though I see the impacts beyond sort of healthcare on health of other sorts of factors. Can we guarantee a right to health? So if the panelists could speak to that, that would be really helpful. And we actually had a few students who emailed in with questions which were sort of around this area. So I'll run through in order. Sridhar, did that question make sense? And if so, could you say something in response to it?
Sure. So let me just be brief and sort of focus on a couple of things that I thought were interesting about that question. And I apologize if I don't satisfy the question. So the first one, I think, is the classic thing of, well, if you're going to talk about rights, you need to talk about duties, because a right just doesn't hang in the air. For a right to be meaningful, it's a right to something that someone then has to fulfill. And so that's one kind of right and duty kind of, I think it's called the perfect obligation, which sort of comes out of Kantian philosophy that says, if there isn't anyone that has the duty, then you've got no right. So, sort of be careful about how you use the language of rights. And I'm perfectly fine with that. I think that we're not here talking about there is a lack of agent or actor who can satisfy the right to health or the right to health care. What we're saying about health care is that, and I didn't specify whether it should be health insurance or what sort of financing system or anything like that. I think we can talk about the details. I just want you to get me, sort of agree with me in this first place that, we think health is valuable and therefore we should sort of make it into some sort of right, a moral claim that sort of turned into a right. And then the duty can be specified and we can talk about that. So healthcare, and then the kind of idea of determinants of health or what we call social determinants of health, these are much more broader and they have sort of, all the way from, whether we're talking about social structural disadvantage over the life course, whether we're talking about access to basically, as the example was shown, is like, if somebody's sitting at home and there's a vaccine center 10 miles away and you can't get it, you don't have access. And so if you had a right to that health concept, then we would have to ensure that this person has the ability to get that vaccination by providing some sort of mobility or at-home vaccination, et cetera. So that's the kind of work that does. And the duty specification might be able to sort of address that from a context sort of analysis or something like that. I really want to also, because rarely do I speak to an American audience, and I'm going to try this out and see what you all think, is that one of the things that COVID has done is really brought to the surface that our health is interdependent, right? So we have constantly, and I sort of growing up in America, is sort of this idea of, it's your responsibility, your body, everything is yours. You decide what you're going to do. And so what you do to it is your sort of decisions. And then, and healthcare is there for your tragic events or for things that might go wrong for you. What we don't understand and we didn't take into consideration is that our health is interdependent, not only within a community, but also across the world. So what happens to somebody on the other side of the world will affect you tomorrow or in a week from today. And so this interdependence has, I think, really not been present in philosophy. So if you think about our social contract theories, and we talk about sort of this idea of the reasons of why people come together, we never say health, right? Hobbes, Locke, Kant, they never talked about health. This is something that urgently needs to be done, is that we need a 21st century conception of a social contract. Even Rawls, who's considered to be a greatest modern social contract theory, didn't have a very good understanding of health either. And so that's been some of my work. And so why I'm bringing this up is that in terms of living together, it's not just that you are personally responsible for your own health, that is true, but I think that we clearly now recognize that as human beings, our health is interdependent, and therefore we have some level of, benefits and burdens as you might use it, or duties to each other in terms of protecting not only each other's health, that your health is going to be better by being sort of a good duty bearer about the health of others. So I'll stop talking now. Thanks.
Sridhar, thanks. You answered the question perfectly, at least as far as I understood the students who asked this in class the other day. So that was excellent. And I'm actually going to jump straight to Professor Thomas and then jump back to Professor Cherry, despite what I said, because I know, Florian, that you've thought a lot and done engaged considerations of access, but also thought about different responsibilities that folks might have in light of availing themselves of a potential right to health, or again, whatever exactly the language is. So I wanted to turn to you and see, either in response to the original question or in response to what Sridhar just noted, are there, as a practicing physician, I mean, especially in COVID-19, I mean, you were up against some really tough stuff. I mean, are there expectations that you have or would like to be able to have of citizens like me who show up to see you?
Well, absolutely. I expect patients who come to my office to be truthful in terms of sharing any symptoms they have. We ask them, do you cough, do you sneeze, do you have a fever, have you been around people with COVID? That's part of the social contract. I don't want my patients to endanger others in the waiting room, our staff, or me personally. Clearly, there are expectations. And with the example of the patient I just mentioned, what is my obligation towards a patient who refuses to be vaccinated, where obviously, and I say that as somebody who's had four COVID vaccinations, the vaccinations are not 100% effective, and somebody who doesn't get vaccinated may very well not get COVID. How do I respond to a patient who refuses to be vaccinated while at the same time expecting me to give them medications that can put them at increased risk of having a serious case of COVID or dying from it? I can limit my response to, I document what I told the patients to do. It's up to the patient to follow my advice, but it's still a ethical problem for me. I cannot discharge the patient from my practice, even though I know that the drugs I'm giving the patient may kill the patient, with or without COVID in the picture. So I think it's really important to have, as a society, this conversation. And of course, that conversation essentially circles around the fact, the question of how much my own exercise of my freedom may impact somebody else's exercise of their freedom. Can I walk around without a mask and possibly endanger a person around me? And I mean, regretfully, the range of opinions in all societies is huge, and we haven't made much progress in narrowing these ranges. And of course, that to some degree goes back to the question we addressed when we started out. There is no consensus and there is no platform at which to discuss how a society should address health and healthcare delivery. Do we provide $1 million worth of care in the last year of a person's life, or do we ration that when that person is close to the end of their life expectancies? So this is a problem that every society faces, and I don't know how to move that conversation forward. But we're all suffering because of lack of that conversation.
Thank you, Dr. Thomas. I mean, a wonderful, even if challenging example of the effort it might take to get to, I don't know, a communal bond or something like that once we grant Sridhar's point about interdependence, right? So once we have that, what are both the burdens and also the benefits? What are the responsibilities that folks have? And again, for our usual listeners who call in all the time to the COVID ethics series, you'll recall an early session before a vaccine was out in which we spoke with Professor R.J. Borgers, who was coming up with a way to exercise safely during COVID. And one of the main one of the impetuses of his work had to do with what happens if you train too hard for a marathon, you break your leg, and you now have a greater burden on the system, right? But that kind of thinking runs in a very different direction, right? Florian, as you said, there's no consensus on this, to folks who are more focused on individual freedoms. So excellent. And now I want to turn to Professor Cherry. Mark, you have this big question before you, as well as a bunch of conversations. So jump in, give us a good answer, and then we're going to move to some other questions from our audience.
So I'll only point to a couple of important issues. In particular, I will reemphasize just what Dr. Thomas noted, the immense lack of consensus on the nature of the right, the good, the virtuous, or even what would constitute the concept of health, even as conceptualized. It's a very set of ambiguous terms. Would note also the idea of costs at the end of life, very important set of issues for which we are going to become ever more pressing because of the aging population in Western Europe, Canada, United States also, though we're still a little bit behind the curve, but it's still immensely expensive end of life. I have a suspicion, but I have no empirical proof, that the push in places like Canada towards active euthanasia is attached to the expense of the immense cost at end of life. They're now at more than 2% of annual deaths are active euthanasia. Again, I don't have any empirical data of the claim. It's simply a suspicion I have, and I'm trying to find ways to connect those dots to see if it exists at all. The next point to just reference has to do with interdependence. I think that's a very key issue, but we still have to think very carefully through how much we wish to think of state intervention into the kinds of individual activities that people engage in. For example, typically when the states have intervened with regard to things like smoking, and the claim with regard to smoking was that smoking was bad for your health, that these costs were passed on to others. Therefore, the government could in fact intervene and restrict where one could smoke, when one could smoke, and so forth. And many people heralded this. And then the government went another step further and in many places began to try to regulate things like trans fats, salt intake, soda intake, again, for the same reasons. It impacts one's health negatively. The costs are passed on to others, in these cases, typically financially, through increased insurance premiums and so forth, and even taxpayer-financed healthcare. And so the view was the government had the authority to regulate those kinds of activities. Some people have noticed that this same model argument would include things like mandatory vaccination. That again, if one doesn't vaccinate, one passes those costs on to others, at least potentially, and as a result, at least if it's a very dangerous disease, that there would be authority on the part of the government to require vaccination. But you still have to be very careful how far you wish this type of model argument to go. It's worth noting, for example, that in the United States, sexually transmitted diseases cost somewhere in the neighborhood of $21 billion a year in direct healthcare costs alone, not including indirect costs, but just direct healthcare costs, which again, they're passing those costs on to others through increased insurance premiums, government financed care, and so forth. Do you want the government to see itself as having the authority to intervene in those kinds of intimate activities? Well, if we buy the analogy, the argument, it might look like the government would have those kinds of authority to intervene. So it's worth being very careful about and thinking through how far one wants to go, even when one recognizes very important issues of the interdependence of persons and of states around the world.
Thank you, Professor Cherry. So, I mean, as we think through what might follow practically from this idea of a general responsibility, maybe to be healthful in light of accessing healthcare, broadly accessing some kind of a right to health, government regulation is one possible option, and something which has not gone well in a number of cases, and also, as you rightly put, might be something which folks aren't, or which folks are less interested in. So I appreciate that. I'm going to do the annoying moderator thing of taking a hard stop on this really interesting thread of the conversation to turn into some questions we're receiving from the audience. So with my gratitude to Emily Southerton, who has shared this question, which she directs at Dr. Venkatapuram, and then after, Sridhar, after I send it to you, if Florian or Mark, you have a comment, please feel free to jump in. After saying some nice things about the panel, thank you, Emily, she says, here's the question. If healthcare is an instrument, how can the tool be used equally across a variety of social, racial, and economic backgrounds? Given the acknowledgement that healthcare is built on relationships and there is racial bias within healthcare, how should healthcare take shape? Could you be more specific about your point about healthcare as an instrument? So that is a host of huge questions, Sridhar. Please go. Anything would be helpful.
Thanks very much. I think, thank you very much for the question, Ms. Southerton. I want to just take 30 seconds to say, sort of just respond to Professor Cherry. You know, I find myself in surprisingly quite in agreement from the Republic of Texas, because I actually do worry about the role of government in the personal. And I think that as we seek to help people live good, flourishing lives, we should be constantly aware of how far we are reaching into people's lives in order to be able to do that. So I think it's an absolutely right on sort of concern that as we think about the value of health and health in people's lives, we should really carefully consider how far we are actually sort of stepping into people's lives. But, you know, but then the example of sexually transmitted diseases, I know was meant to be scary, but I just want to say that the government already does do that in the United States. In particular, is that it moderates and has for decades regulated what kind of sex that you can have. It modulates the sexual violence. It modulates all these other kinds of stuff. So the question around, you know, can this stuff? And so very recently, it also, I think a decade ago, started sort of penalizing individuals for passing on HIV without, you know, sex without a condom. So that in itself is moderating. So it's not about something that may happen in the future. I just wanted to say that it already happens. And so we should sort of think about it. But I also appreciate your concern that, you know, the right to healthcare there's no way of avoiding that healthcare is an expensive thing. In America, particularly, right? So if you look at that, I'm not going to go into all the details, but there is a real worry here, and I share it with you, that when we talk about the right to health, the right to healthcare, at the end of it, there is a financial sort of thing here, and we need to really think about how the system is sort of distributing these financial costs. And I think that that's a worry that I have too. And I just wanted to say that I share all of your points, and surprisingly so, but I just think that they were just sort of really great. So the second thing is that regarding the instrument of healthcare, as I'm sort of seeing it, is that I don't see just that healthcare is an expensive commodity that we have to figure out how to distribute fairly across individuals. What I'm saying is that healthcare is one of the things that helps people live good, flourishing lives. And you can think about what do we do in terms of ensuring other kinds of capabilities and freedoms in people's lives. So whether it be, you know, how much do we spend on making sure that the roads are safe? How much do we spend in making sure schools are able to ensure that all children are literate and numerate, et cetera? So, but this particular question, I think, really speaks to this idea of, you know, fair experience of healthcare. which is that when different kinds of people go into the healthcare system, that they should be able to expect the best quality healthcare available, and it shouldn't matter whether you're a man or a woman, young or old, black or white, or whatever it might be. And I think the role of racism, discrimination, and all these other kinds of biases is a matter of justice. It's not just a question of, oh, there's racism in healthcare. It's actually certain kinds of people are not getting the equal opportunity to live the kinds of lives that they are entitled to. And so I do think that it's a much bigger problem than people are currently framing it as. And I hope that we sort of keep sort of pushing that forward and sort of saying that it's not that this doesn't exist, it does exist, and I've experienced it myself, but it just means that we really need to name it for what it is and sort of also talk about the moral dimensions of this. I hope that that answered your question, and I'm sorry if I didn't. Thanks.
Excellent, thank you. Well, I will not speak for Ms. Southerton, but yeah, I hope it did as well. And Emily can always add more questions or send something along and we'll follow up. So thank you. Since you did respond, have a comment to Professor Cherry, I just want to be a polite moderator and see, Mark, in 30 seconds, do you have a response to Sridhar's earlier opening? And then I'll open up the question more broadly to you and then Dr. Thomas.
Being an arrogant Texan, I'll surely take more than 30 seconds. But I think you're right. There are immense expensive issues that we have to be honest about. The United States, for example, for those who don't know, if we use just 2019 data, which comes from the OECD, puts about $11,000 per capita into healthcare every year, versus the United Kingdom, which is at about $4,500 per capita using US dollars in 2019. The question is a really good one. What are we buying with all of that money? And it's important to be honest about that. Second piece of it has to do with, again, being honest about some of the things we do well. Well, just because insofar as we change things, improve things in terms of access to health or access to healthcare, you don't want to undermine what we do properly. So, for example, in terms of prostate cancer and in terms of breast cancer, the diagnosis and success rates are better in the United States than in Europe or the United Kingdom. We do better. Now, if you dig down into that data, what you will find is, again, differences amongst racial groups. So just to pick on prostate cancer, in the United States, you have deaths of about 18.9 per 100,000, as compared to the EU, which is about 36. Overall, can vary by country, but so we're doing better. But again, go into that data. For African Americans, it's more like 38. You see the distinction. However, for Hispanic Americans, it's more like 15, much less. For Asian Americans, about 8. So we have an immense differentiation, and one needs to look at that data and get a sense of what might be causing it in terms of the implications for how one best treats one's patients to try to get access to good quality care. In terms of issues of things like equality, again, I think your point is really important for us to think about what are the issues at stake in terms of focusing on equality, in terms of best exercising people towards good quality health. One should distinguish, for example, between an egalitarianism of envy, where we're just sort of envious that some people do better and we want to level them down. That doesn't seem to be terribly helpful. Instead, we might want to focus on egalitarianism of altruism, find ways to help people do better and raise everyone as best as possible and in appropriate ways. Or some people might even wish to give up on equality altogether and just focus on a basic humanism, right? You don't really care how well off Bill Gates and others are doing. They're billionaires. I'm a philosophy professor. Really hard to conceptualize being a billionaire. On the other hand, I do care a lot about the poor and trying to find really good ways to help the poor do better and better and better seems to me to be a very important set of moral issues, which can be addressed without kind of a hyper focus on worrying about people who have billions of dollars. So that's a sort of a quickie, not quite 30-second response. I apologize for the time. Very important set of issues you raised, though. Thank you so.
Thank you, Professor Cherry. Dr. Thomas, in response to the question that was originally raised by Ms. Southerton, any comments from the perspective of a practicing physician?
Well, when I think about the role of government, I think about the role that government is currently playing in differentially deteriorating the health of certain groups. And I think of the intersectionality of health, access to health, socioeconomic background, and ethnicity. So I would advocate that an affirmative action approach is indicated, given that we know that certain populations in this country, in the place where they are obliged to live, have a far greater exposure, government determined, whether it's federal or local is another question, to environmental problems. Specifically, we know that waste disposal facilities, that power plants are located in certain communities with much greater likelihood than in other communities. So my personal health behavior can only go so far if I'm obliged to live in a polluted area, and we know that decreased pollution actually is one of the factors being discussed as being the cause of a decreased stroke incidence. So pollution directly affects health, whether it's vascular health or cognitive health. All of that is well established. And our government forces certain sectors of the population who historically have been disadvantaged since this society was founded, and exposes them to worse health and worse healthcare. And I think that is a discussion that is just as relevant as restrictions that government imposes on people in terms of their freedom to have unprotected sex. And I think that discussion is also not actively being pursued at this point to a sufficient degree.
Thank you, Dr. Thomas. An excellent perspective, as always. We have more questions coming in, both directly to me on Twitter, email, and also in the question and answer area. So I'm going to turn to those quickly. I'll let folks know we do have a hard stop just before 1:30, and we'll move pretty quickly through these so the panelists can have a last word to leave us with. Two questions I want to put out there for the panelists to let you all jump on as you wish. The first is a comment from our friendly neighborhood virologist, Dr. Gary Monk, who notes that, I think deeper in the question is a belief he holds that there are vaccination-related duties, and he cites some popular sports-related examples of Novak Djokovic being banned from the Australian Open, sort of on a negative side, and then on a, I guess, positive side, they allowed him in. Kyrie Irving playing the first game in Brooklyn on Sunday. Again, folks who have not been vaccinated, sort of in a public kind of way, not been in favor of it. So taking up how extensive the kinds of duties are is one open question to the panelists. The other, I see here from John Licurto, is the big question about if there really is a human right to healthcare. This presumes that human rights exist, and what are they, where do they come from, and all that. So would any of the panelists like to jump in? The question from Professor Licurto, I suspect, is too large to take up here, but any directions you could send him where you're thinking for the origin of human rights, and then anything on these sort of very notable sports-related figures and what that might mean for communities thinking about vaccine requirements. So either question, Sridhar, I'll just go in order and send it to you if that's all right. Sorry to put you on the spot. and then to Mark Cherry and Florian Thomas.
Yeah, so just very rapidly, quickly, and probably not sort of very linked together. So to the question about human rights, I saw that. I think that rather than take a quick answer, I would sort of point them to the United States Declaration of Independence and the Constitution and sort of say, you know, where do you think that those things came from before they wrote it down on a piece of paper, and see what you believe about the sources of those kinds of ideas, and if you think that they're valid or not. And while if you think that they're invalid, then that would make the Declaration and the Constitution sort of not very, you know, sort of justifiable. So there's that kind of days and years you could spend on that puzzle. But the lawyers also basically at this point regarding human rights say, well, it is international law. And so there is sort of not a question about whether it is or not. That's the law. And so you have to follow it. And I think more recently, philosophers have been working on sort of the philosophical justification of human rights, and there's different approaches to it. So I would encourage you to look at all of those different kinds of literature and what's going on. The sports figures is an interesting example in two ways for me. One is that you're right, there is sort of brings up this idea of you know, what is interdependence and what are the rights and duties of those kinds of stuff. I also think there's a second layer here of public personalities and what their role are, because it isn't just that they're doing it privately on their own, they're doing it publicly. And so there is something else going on here about sort of using a sort of public platform to advocate for various kinds of things. So we need to think about that as well. But related to that, I think fundamentally in the United States and elsewhere, we just don't have an appreciation of public health as much as we do of medicine and healthcare. We just simply do not appreciate or understand what are the different aspects of public health. A lot of people think public health is water, sanitation, and sewage, and you know, collecting garbage. Public health is so much more beyond that. And even now, you know, if you look into social epidemiology, it's about, you know, so many things about how we relate to each other and what's going on. So I think all of those come to mind when thinking about that particular question. I'm going to stop there so that I can give other people some few minutes before the last time. But thank you very much for having me on today.
Excellent. Thank you. It was very helpful and raises, we'll jump to Professor Cherry, but raises a question written very nicely by Dr. Lemley in our Q&A, which I'll send to Dr. Thomas, asking whether physicians really should be agents of the state, given these kinds of obligations and considerations of public health. So, Mark, help us out with those two big questions, and then Florian, wrap us up with whether you and your folks should be agents of the state. So Mark, you first.
So Professor Pilkington's poking me because he knows that I have published against the idea of human rights. I think one has to distinguish between the idea of humans as bearers of rights and the human rights language that developed out of the French Revolution and that has become part of sort of the universal declarations that have come out. I think those are very important distinctions that one must make, because there are different traditions and different ways of talking about it. And it's unclear to me that they're related to each other in exactly what way. So the modern language of human rights, I think of as no more than a kind of a modus vivendi. And may Texas preserve me from international law. But in terms of things like vaccinations, I think one again has to think carefully and make distinctions. There are very important distinctions between the government coming in and mandating a vaccine for human papillomavirus. The way you get HPV, not always, but most of the time, is by very intimate contact that one knows is risky. On the other hand, there's the MMR vaccine, which just seems to be very important because of the way in which measles, mumps, and rubella can really pass on to others through very casual contact. Those are very different issues for us to think through. Then one has to figure out where exactly COVID goes into that category. But that's how I would think it through in terms of those different kinds of categorizations. Anyway, thank you all so much. Really appreciate it.
Thank you very much, Professor Cherry. Dr. Thomas, wrap us up here. Again, the question from Dr. Lemley: insofar as physicians are obligated to maximize the delivery of healthcare, are patients better served by physicians who are agents of the state or agents of industry?
Well, I'm always reluctant to look at black and white scenarios. I think, first of all, physicians have to follow their conscience and have to look at patients from the patient's point of view. What stands between the patient and optimal health? What stands between the patient and optimal health may be government-sanctioned pollution in their environment. I certainly wouldn't want to see myself as an agent of perpetuating that. What stands between a patient and health may be the cost of medicines. I know states are trying to limit the cost of medicines, and I'm gladly to serve in that capacity when I advocate on behalf of my patients to legislatures regarding access to medications. So I think first and foremost, I'm an agent for the patient. That's how I interpret the Hippocratic Oath, but I function in a system, and that obliges me to look at multiple needs for compromise every day of my professional life.
Thank you, Florian. And I appreciate both the reference to conscience. We have a COVID ethics series which aired a month ago, and everyone can access that on our library website. So that's a perfect segue. Thank you so much to the panelists. We'll do a couple of closing announcements, but I'm in your debt. You all have been phenomenal, and I hope have raised the bar and raised the level of conversation among those in the COVID ethics series community. Anyone interested in continuing medical education credits, you can do the fancy thing with your phone and use this QR code. We will also send you only if you attended. So if you have many friends who are trying to get in and could not, unfortunately, they're out of luck. If you attended, you'll receive an email, which will also have the REDCap link to fill out the survey you need for CME credits. Please check out our library webpage, library.shu.edu/COVID ethics. This has recordings of all of our episodes with a number of really interesting topics with some great folks. So thank you, especially to the panelists. Thank you all for coming. And yes, I always forget, we are a podcast now. So if you prefer to listen, if you have friends and colleagues who are listeners and not watchers, please share the podcast with them as well. So thank you all very much. And I hope to see you again next month when we have our next session. Have a good day.